I'm super happy to have Dr. Andrew Herring today. But before we get started, I'm just going to give some items for you to keep in mind. The objectives of this series is to use a case-based learning approach to share experiences, educate, and disseminate the latest evidence based data on use of medication and other therapies for treating stimulant use disorders, as well as to generate a network of providers and provide a reliable forum to discuss stimulant use disorders and their treatments. Also to present the latest evidence for treatment of stimulant use disorders, to guide treatment decisions, and to destigmatize treatment of stimulant use disorders. Some Zoom items, please feel free to drop your questions and answers in the chat. We're going to be monitoring it, so don't be shy. If you feel free to participate, please raise your hand, turn on your mic, and feel free to discuss things. Please make sure to attend the full lecture, so at the end of the session, you can complete the evaluation provided. If you have any questions, please send them to Dami or myself. I'm going to be putting my email in the chat. And we also have some upcoming sessions in 2 weeks, November 15, and we're very excited. So please, if you want more information on the session, we're going to be sending it out. Finally, none of these planners for the educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or patients, except Dr. Shopta, faculty for this educational event, has received clinical supplies for research from the following providers. And all of the relevant financial relationships listed for these individuals have been mitigated. So thank you, everybody, for being here, and we're really excited. Dr. Taylor.
All right. Hi, everyone. I'm Taylor Doctor. I'm one of the addiction medicine fellows at UCLA, and I trained in emergency medicine at LA County. And so it's my pleasure to introduce Dr. Herring today, who's been a huge inspiration for me as a emergency medicine and addiction medicine trainee now. And I'm sure many of you are familiar with his work with the California Bridge program. And so I will read you a quick and very impressive biography, and then we can go ahead and get started. So Dr. Herring graduated from Harvard Medical School and completed residency in emergency medicine at Highland Hospital, Alameda Health System in Oakland, California, where he continues as an attending emergency physician and the director of research. At Highland, he's the chief of addiction medicine and the past medical director of the Functional Restoration Pain Clinic. Dr. Herring has led national efforts to transform hospital-based care for substance use disorders, and his work has been featured in local and national press, including the New York Times, Los Angeles Times, and National Public Radio. Dr. Herring also co-founded and is a PI at the California Bridge program, one of the largest state-level efforts to promote access to medication for opioid use disorder in the hospital setting. And if you're not familiar, you should certainly check out their website because they have incredible resources for all kinds of providers and treatment settings. Dr. Herring's research has been funded by the National Institute of Health and the Patient-Centered Outcomes Research Institute and has been published in numerous journals, including JAMA and Annals of Emergency Medicine. His work focuses on treatment of substance use disorders and pain management, and he's conducted health policy research as a Fulbright Scholar in Central America. Dr. Herring is board certified in emergency medicine and addiction medicine and pain medicine and is assistant clinical professor at the University of California, San Francisco. And so I'll turn it over to him.
Great. Thank you so much. I am so happy to be here. This is awesome. So my understanding, this is going to be super interactive. So I'm not sure how we can jump in with questions, but we can take questions at the end or anywhere along the way.
I'm sorry, can you
yeah.
swap your displays? We're seeing your presenter slides. Just on the top where it says swap display.
There we go.
Perfect. Thank you.
Thank you. So we'll talk about the emergency department and focus on methamphetamine use. The no disclosures. Um, we talked about the bridge, so I'm very lucky. I get to work at an amazing hospital, Highland Hospital in Oakland, and see things in the ER and the inpatient, in the clinic, in the ambulances, in the jail, the shelters, all these kind of spoken settings that we treat people with SUD. So it's a very rich environment. And then I've got a great group of colleagues all over California and all over the country that are doing similar work. So my disclosure also is I love emergency departments. Emergency departments are really it's important just to pause and recognize that financial agendas, structural agendas are really conspiring to make emergency departments difficult to work with. But fundamentally, they're the hole in the fence. They are the one place in the American medical system where by law no one is ever turned away, and they're open 24/7, and they're highly equipped with everything from food to advanced therapeutics and diagnostics. They're amazing places that I really think is someplace that all of us should be all hands on deck to help the people in the ER. And so in your own careers, really always be thinking about how can you partner with your emergency department? How can you meet people there and start high quality care? This is just more important than ever as we're kind of going through a backlash moment. Just remember, the drug war didn't work, and that we really need to always be advocating for equity in our healthcare system and social services. And that's just a fundamental, I think, a moral need that all of us have to push forward. Other, is that this is uh, though this statement that drug users make rational decisions, this is Carl Hart. I'm sure many of you see that. I think is really important because what it does is it pushes accountability on us to create services that are attractive, and that the converse is this whole notion of coercive care, which right now Prop 36 is very, very pertinent. So again, this is just important to stand up for the notion that coercive care doesn't work, and that we really are on the hook to create attractive, convenient, seamless, effective, appropriately situated care that people want to participate in. And we need to appeal to them as with the respect that we would appeal to other people that have a discriminatory choice. Harm reduction and treatment they are the same thing. So we all got to be harm reductionists. If you're on the fence, get off of it and just make it part of your practice. Um, and a lot of what we're going to talk today is what Loris Maddox, who's at the California Department of AIDS, and an executive director of the Harm Reduction Agency in Alameda County, calls no shit science, where you're just really bringing to bear all your tools. Interpersonal tools, pharmacologic tools, structural tools in a way that benefits people wherever they're at and moves them a little bit closer towards wellness and a little bit away from harm at every point of contact. So stimulants, we're mainly going to be talking about methamphetamine today. This is just a fun slide. I don't know where I found this, but I found that there's now a tobacco plant that can be genetically engineered to produce cocaine. So right now we're seeing a lot of methamphetamine, but who knows? Cocaine could come back with more prevalence. There's a huge distribution of stimulant use between countries, in some places where it's quite rare, and some places where it's quite prevalent. Here in the West, we obviously have a tremendous impact or presence of methamphetamine. You talk to folks on the East Coast, and there's very little methamphetamine in a lot of those dense markets like Philadelphia, New York, and New Jersey, and all of that. But the Southeast, there's lots of methamphetamine, and here, of course, there's lots of methamphetamine. Why that happens, we're not really sure. We all know that its role in overdose deaths is increasing. The specifics of that are still being worked out, but it's certainly a rising problem. So jumping into kind of this frame of the emergency department, the beauty of the emergency department is you're going to see methamphetamine in a really wide variety of ways. So this is one of the ways. So this is a 32-year-old woman who's coming into the ER with her son who's sprained his ankle while playing soccer. And this is not made up. These are real cases. So this is this notion of methamphetamine use that's disclosed during an unrelated medical encounter. And in following people that we've initiated for something like mirtazapine or connected to care in the ER, I'll see that there's a whole group of folks that are using methamphetamine who have really quite a lot of contact with the medical system. Um, they're going to their primary care doctor, and they're going to their OBs, and sometimes the contact is a little it's starting to get a little disordered, starting to focus on maybe some perseveration over somatic things. But they're there. So the point here is just that creating spaces that you allow people to be open about methamphetamine use is really important to kind of maybe recruiting people into treatment, into reducing use, kind of further back up, as opposed to waiting till they've had a longer term exposure you know, to methamphetamine over time, which causes these inevitable neuropsychiatric changes that make engagement all that more difficult. So there really is this upstream population that's out there, and can really benefit from engagement and treatment. And so this would be thinking about it as a cycle. This would be this sort of initial exposure or increasing use, where it's often subclinical, and then heading into the binge phase, which with lack of sleep and psychosis, which is the more kind of typical kind of imagination for how you're going to see methamphetamine in the emergency department. So this framework kind of connects to a larger idea of clinical targets. What can you do for someone? So for example, for this person who is relatively functioning, the first thing that we're going to focus on is just sleep. It's just, the question would be, are you sleeping every day? And really because for me, that is a tipping point into severity, is when you start losing your sleep, and you start going, every week you'll have at least one night where you don't sleep, and that's the initial descent into more severity. Then that as it gets more severe, that is kind of the fulminant ER presentation of a psychiatric emergency, where you're in crisis, you're on a 5150 hold, you might be in restraints. And many of those folks, if you haven't asked them, in their stable condition, will explain to you that they commonly will not have slept for 7, 14, 21 days. It's not uncommon at all for that really extreme presentation. And then afterwards, they crash. And so that's the so-called washout. So there's this phase of withdrawal, exhaustion, which is like this physiologic withdrawal, exhaustion, hunger, dehydration. They might have rhabdomyolysis, all of these sort of recovery phases. The other place that people present is through opioid co-use. So the opioid overdose in someone who's primarily using stimulants and is really trying to come down, and they'll use fentanyl, they'll come down too hard, they'll overdose, or they're sharing foil, and there's residue resin on the foil that they don't have a tolerance to, and they overdose. That's really common presentation. Trying to figure, it's another target, is like how to work with that population. And then finally, there's all of the cardiovascular complications of methamphetamine. So every emergency department has seen, physician in California has or will see, a case of aortic dissection, where someone using methamphetamine has their aorta splits open, tears, just due to the intense hypertension that you'll experience when you're using methamphetamine. And then the other common repercussions of use are COPD/asthma from the inhaled smoke, the cardiomyopathy that can be so tragic with the predominantly right-sided heart failures, pulmonary hypertension that we can see in very young people, which has been the basis for a lot of these collaborative programs where addiction medicine and cardiology are working together to help reduce use, so that heart can recover. And often it can recover, and sometimes it can't, and you're looking at sort of transplant and other long-term stuff. Then finally, strokes, of course, infection due to either neglect or injection use. Trauma is an incredibly common presentation, both as a victim of violence, and through vehicular stuff or just general high risk physical behavior. And then, as I mentioned, rhabdomyolysis and seizure. So kind of putting it together in kind of an approach, what you can imagine is that there's this arc of beginning use, and these people are in the ER. Then there's this sort of escalating use where you're starting to see signs of early decompensation. So this might be the person who's just seeing, starting to see little shadows. They're starting to be thinking about their neighbors that are talking about them, or people creeping up on them, or they might have a complaint about a somatic thing that's not there. Um, and so they're very, you can talk to them, they're with you, but they're starting to get these signs of consistent use. And then there's the intense phase where they're agitated, they're bizarre, they have fulminant psychosis, and then there's the crash. So each one of these folks represents a distinct opportunity for a tailored intervention in the ER context. So for this woman, this is where we're really thinking about getting her to recognize the potential risks that are coming down the line and to pull back from this process of moving to the next phase, using tools like having a olanzapine, Zyprexa, 5 or 10 milligrams as needed, to frame it as to slow down your thoughts or help you sleep. Really targeting avoiding the multi days without sleep would kind of be the focus there for her. Um, the Then when you drill down to what that really means, this would be specific prescriptions I mentioned, the olanzapine, maybe trazodone at night. You're going to be talking about this idea of toxicities that Philip Coffin has brought up, which I think is really great, where you have someone who's ambulatory and able to really engage on long-term potential risks and having those conversations about what could be coming down the line and promoting engagement with primary care. And as with all these things, just really prioritizing engagement, the sense of belonging to a community of people that will always be there for them. Then as you're moving up the ladder, right? So this would be the kind of next level, right? He's a 45-year-old guy he's crashed his motorcycle and he's broken his shin. This is incredibly common, right? And then through that, it comes out that, he's not speaking, he's starting to show signs of paranoia, maybe agitation. And again, you're just jumping on that with your tools again. Some kind of mild antipsychotic, psychoeducation, getting in there with your navigators, and collaborating with the trauma team or the medical team, to kind of combine this treatment with your long-term plan for engagement with behavioral health and continued medication management. The final presentation that you're going to see is the person who comes in restraints, as we mentioned. So this is probably not the most common presentation. We don't really know, but it's the one you usually think of, but certainly not the most common presentation, where you're in the phase of using whatever your department uses to bring them down. So if you haven't seen it, it's a very traumatic experience for everybody. Requires all the kind of the unpleasant realities of coercive care, where you have to hold people down, you have to use large doses of sedatives just to get them down so they aren't at harm to themselves or others. Now, this person is often kind of just forgotten about, right? Because that initial moment, you just can't engage with them. So then you have to have a team that's able to follow them along, because they're going to go from being really, really up here, and then they're going to crash. So this same person that comes in agitated, might end up being there for the next 30 hours. And not sure, how many of you have seen this, but it's quite dramatic. So that people really can be immobile for 12, 18, 24, 30 hours. They have a very very specific kind of pattern of like these little mild clonic twitches. They'll be lying there and they'll wake up hungry, tired, irritable. And that's that sort of presentation that can really lead to a sense of dehumanizing and antagonism with medical staff because this person wakes up, they just seem mean and like they don't want care and all of that. So this specific washout, I think, is actually a huge area to think about how we could do a better job um, of promoting a good experience for them, treat those withdrawal symptoms. Maybe this is where bupropion can help, acutely in the ED. It comes on pretty fast, maybe 300 bupropion while they're kind of waking up could help improve mood. Treating hunger as as an actual, almost like a clinical need for this person. Um, and then really creating a clinical encounter frame that is able to maintain this long distance. Like you've got to be able to like focus in on someone for what could be 24 hours, waiting for that moment where you can engage with them and pull them into care.
Doctor, just to interrupt, we had one question
Yeah.
about the first case. Someone was asking about like what concerns we might have related to her being a primary caretaker of an injured child while also under the influence.
Oh, yeah, that's a good question. There are a lot of parents who use methamphetamine. I mean, a lot. So in this case was very much meant to be meant to be the person who's not decompensated. And so clinically, in that case, you're not seeing a risk to the child. There's no signs of non-accidental trauma. It was just really was just a kid playing soccer. And we've worked with lots of people who use methamphetamine as a performance enhancing drug to help them get through the day and do a little bit better job at a taxing set of tasks they have in front of them, usually mixing this combination of caregiving and work. It's just incredibly common. Um, so I think I would just sort of see the determination of risk to child and the use of methamphetamine as being very distinct things. They sometimes are the same thing, but they're really evaluated differently. So if you see trauma, it can be whether the person's using alcohol or no substance at all. And they could also be connected, but not necessarily. The great. Any other questions?
No specific questions, some good comments about let me find it. Where did I go? Just considering also use in the setting of trauma related to sex trade for survival and the complications of how the delusions can also be very interesting and how it can also create trauma when the patients feel unheard or not believed when they bring up some of those delusions to providers.
Yeah. Yeah.
Then one other kind of side conversation about how it's interesting how insurance won't pay for detox in clients like during a washout unless they're being provided medication for that, or if they were admitted, washing out wouldn't cover that admission unless they were also being treated for like a comorbid illness. I'm a little protected from that when I was at county because we're like billing exempt from Medicare. So these are interesting comments to me for sure.
Yeah, yeah, I know that withdrawal state isn't really a clinical entity that's really been defined, but it's clearly something, right? It's this physiologic exhaustion that's very stereotypical and common, and it's a thing that really hasn't been defined. And if it has, and then because it hasn't been defined, we don't have a really good approach to it. Like how long is it, and how do you intervene on it? When do you wake someone up? Because clearly there's a need for physiologic recovery and sleep, but it seems to like go too long. You
Yeah.
feel,
And if you wait too long, they get like deeper into it. And I've seen patients who like you can't get them, they won't walk. They like literally can't walk. They're too exhausted.
yeah,
Yeah.
yeah, yeah. So I think there's a whole world of kind of focusing in on that. But maybe we'll just wrap up with this sort of hypothetical kitchen sink. So this is our person, that come as the trauma, and they've calmed down. You gave them a little lorazepam in the ER along with your olanzapine. You haven't presented the olanzapine as some kind of like diagnosis of schizophrenia or anything like that. It's just very much framed as a tool to help slow down your thoughts and chill out. You're from and encouraging to think about it as a tool for overamping or sleep or whatever resonates with them. You've given them a clean, safe place to sleep. Um, you haven't really considered their requests for nutrition as being secondary gain, inappropriate, and really understood hunger as like an actual kind of clinical symptom in this setting for someone who may not have really eaten for days. So you've let them have four sandwiches. You've let them have a lot of juice as a clinical intervention. You recognize that they're like crashing emotionally and are most likely to be horribly depressed and hedonic with low energy, and tried to counteract that with a dose of bupropion of 300 milligrams. You're leaning into the interventions you have available and have offered naltrexone or even IM Vivitrol if they're interested, and connect them to your drug medical programs that participating in the state pilot project for contingency management, and they're getting started with that, and you're keeping track of the cardiovascular downstream effects of methamphetamine exposure, and you've seen that they were in primary care and they were on amlodipine and atorvastatin, and you restarted it. So this is sort of this giant bundle that really would be, if we wanted to take the experience seriously, this is kind of what high quality care might look like for someone suffering from methamphetamine in the emergency department. And as you can see, it's a lot. So we're certainly nowhere close to being able to apply that for even a small fraction of the people who do encounter emergency department care, but maybe it's something that we can all kind of work together to get there. So with that, I'd just love to conclude and take more questions and thoughts.
All right, we have one question from the Q&A box. Someone was asking on what form most patients are getting their methamphetamines. Do they get pills diverted from legal sources, crystal from illegal sources, a mixture?
Where I am in, I mean, gosh, almost, through the California Bridge Emergency Department network, almost everyone most are smoking crystal methamphetamine. Um, Pipes, foil. Then there is a group that are injecting, but it's much less common. I'm sure all the colleges, I don't know the data off the top of my head, but certainly misuse of prescribed amphetamines, Ritalin, Adderall, etc., is quite common.
Yeah.
But you don't see those folks.
That's been my experience in LA as well. And I think I've noticed a higher portion of injection use in incarcerated population, I think related to the way that they transport it into correctional health facilities is what patients have told me. That
Interesting.
they'll like dissolve crystal in paper, like they'll send letters that have like they've soaked, and then they'll redissolve that into water and then use that to inject. And that's one way that they've like gotten access to it.
Wow. Wow.
Yeah.
That is fascinating.
Someone asked, I think this is a good question. You presented this like beautiful suggestion on what an ideal care of these patients would look like, in particular, somebody who's coming in so intoxicated that they're in restraints. Can you maybe contrast that with what we believe is the reality of what people are routinely getting in this situation?
Routinely, I mean, the most common thing is you get nothing. I mean, you'll probably get a 5150 that may or may not be dropped by the morning psychiatrist. And you may get a social worker that gives you a place to call for residential treatment that may or may not be available in any kind of time frame. That's probably the most common thing.
Yeah. And then Dr. Shoptel asked, can we talk a little bit about who within the emergency department provides this kind of care? Is it ED wide, or are there like peoples who are champions of this important like bridge to meth or bridge for meth? Yeah.
Yeah, that's a great question. The because of the people think about the emergency department as being rapid, but it's really not. Clinic is much more rapid. Street medicine is much more rapid in the sense that you're seeing people for a relatively short amount of time, then you're gone. In the ER, the length of stay for people will typically be at least 4 hours and often 36. So it's kind of this extended experience where you get to see this arc of the kind of natural history of various stages of intoxication and withdrawal. So to keep track of that person, just logistically, you need a navigator team. You can call them navigators, you can call them peers. You definitely want a treatment, quote unquote, or management or MAT pro peer who's able to kind of engage with someone over time and look for those behavioral windows where they're able to be engaged with more of the addiction medicine piece of it. So it takes a team. So it's certainly going to take your navigator team that's sort of promoting the general harm reduction culture, engaging with people, meeting them where they're at, getting all the nurses on board, and then either a up-trained clinician in the ER. They don't need to be an addiction specialist. They don't need to be a consult team. They just need to have particular interest and motivation in doing it, who's then able to drive the more specific treatment options here, like mirtazapine and bupropion and initiating doxypep or some of these things that wouldn't be the just commonly trained for most emergency physicians.
Mm-hmm.
Excellent.
Yep,
Also,
we
we
have
have great participation. Oh, sorry about that, Taylor.
oh yeah, I was
We have
just
great
we have
participation
people
from,
raising their hand.
yeah, exactly. We have Justin raising the hand, and then we have Dr. Sexter as well. So let's see Justin and Dr. Sexter. Justin, I think he goes first. Yeah.
Thanks. Hi, my name is Justin Ells. I'm a nurse practitioner, the medical director of the START clinic over in Boston. Thanks for doing this today. I always am stealing ideas constantly, so I appreciate this. But I do have a question for you about folks who really end up in that persistent psychosis from their stimulant use disorder. Are you using any long-acting injectables in the ER for an antipsychotic? I know you clearly use a lot of olanzapine, but have you gone the sort of bridge to the next step to say, like, we're going to give you a paliperidone injection today because this is your sixth time here in 2 weeks psychotic, or is that something billing wise you haven't been able to figure out yet?
Yeah, so the I'm very lucky because we have our bridge clinic, which is a drop-in clinic, is like very much just like an ER by another name in an ambulatory setting. So in Vega is the most common thing we use. And yeah, we do quite a bit of that for folks that want it. I find that's the biggest barrier is finding folks who want that treatment. Logistically, we can get it to you. We can order it as an outpatient, but then administer it to you in the ED, and we can get around some of these insurance issues. But thank you for bringing that up because I completely agree. Completely agree that antipsychotics are just not, they're not attractive medications to take. They kind of make you feel lame and crummy and they make you dumb, compared to where you were before. Your mind is flying and now you're just like making your thoughts are getting more simple and more slow. I can see why a lot of people don't like it. Um, so if you can get them to make one decision that lasts for a month, that's a huge win. So thank you for bringing that up.
And I think really quick before we get to Dr. Sexter, somebody made a comment in the Q&A that's kind of along those lines of the fact that they've had several patients speak about meth-induced schizophrenia. And it's somebody able to talk a little bit on like, do we really understand what the kind of long-term etiology of that as its own kind of distinct condition is?
Yeah, that's a great question that I'm just going to be re-communicating what I've read, folks that understand this at a much deeper level than I do. But it does seem that yes, that there is a proportion of people who, through long-term exposure to methamphetamine, do develop these psychotic spectrum disorders that can be quite persistent. Um, in whom that's occurring, exactly would that person have never had psychosis without methamphetamine, or how that correlates is I don't have all those details, but certainly in principle, yes, we do see that that association. I'd be interested if anyone else on the call has a more detailed comment around that.
I will just say, in our clinic, we see quite a bit of this, and usually the way I determine whether or not I think someone's really going to have persistence is if they have tactile disturbances in the acute phase of
Mm,
overhanding. That is almost always indicative to me that they will have continued
wow.
perceptual disturbances after cessation of use. And we
Wow.
actually use the PQ-16. I don't know if you guys have used that, but it's a psychosis screener. And so then we like quantitatively follow people's psychosis the way you would follow depression with a PHQ-9. Just kind
Yeah.
of one way to think about doing it.
Yeah.
We see a lot of that here at Tarzana treatment centers where somebody, who's had no indication of psychosis, maybe even, not your typical age or anything, and they'll have meth-induced psychosis. Sometimes it remits as they detox, but many times it doesn't. And my question is, it's from what I've observed, antipsychotics are less effective on meth-induced psychosis than they tend to be on, other kinds of, particularly like hearing voices or things like that. I don't know if other people have found that or not.
I guess it would depend on really how you're defining effectiveness. Certainly in the I see that we can suppress acute hallucination, acute delusions effectively with the right dose, for sure. I've seen that, but that's a very narrow sort of definition of effectiveness.
Right, but even with that, it seems less effective with meth-induced psychosis than without,
Mm.
than regular psychosis.
Yeah, interesting. Yeah.
Dr. Sexter, sorry to keep you waiting.
No problem. Hey, I'm Matt. I work in the LA County Jail.
Yeah.
I have a question that I'm sure like a lot of people have thoughts or experience with. So you mentioned the naltrexone injections, and the research I'm aware of is that with bupropion as far as it being somewhat
Yeah.
efficacious. So in the jail, we're not allowed to use bupropion. So is anybody using naltrexone without the bupropion, and what kind of results are you getting from that? How is that going? It's kind of a theoretical question because we ran out of money, so we can't afford naltrexone injections anyway, but just curious.
Yeah, this is a great question. It certainly comes to me a lot just particularly with people who have recurrent opioid overdoses, which is it's totally separate from treating a craving, but
Mm.
that idea of creating this protection. I just say, we do it sporadically, anecdotally, not systematically. Um, but so that's where we are with that. I'm not sure what the right pathway for everyone is. I'd be interested to see what others are doing and thinking about it.
Yeah. Yeah, we have Nympha Bernabe as well with raised her hand.
Oh, hi. Sorry, I was having trouble
Oh,
unmuting myself. But I actually do have a question. So I am a substance use counselor and the navigator in the ED over at Children's Hospital Los Angeles.
oh, nice.
And I just had I have a question or just maybe to get some insight. We work mainly with youth between the ages of 12 and 25, right? And I would like to know if you've had any experience with providing MAT medication to minors, and what are your thoughts? Because I know that when we began our MAT protocol in the ED, there was a lot of education that needed to be done on our end to provide to our emergency department personnel and just in general, right? Because of the stigma behind MAT as a whole, but then providing MAT services to minors. And so I'm curious as far as like thoughts on hesitation as we move forward and continuing to work with our youth of like for other providers that might have that hesitation or uncertainty of wanting to even provide, these potentially life-saving medications to minors.
Yeah, it's a great another great comment and question. I mean, certainly I just don't see any reason why you don't want to jump in with 2 feet. This is we're all trying to do the right thing. We're trying to help people. And so kind of I don't know, medical legal concerns around age, I think here quite misplaced. If you have a teenager in crisis, you have a teenager in crisis. And the more that you can reach them with the fundamental message that there are people who care about them, and able to help them be more safe, and that there's this whole world of medical tools that can help them with certain psychological, neuropsychiatric states that they might see as a tool to help them. Maybe it's maybe it's depression or the withdrawal that you're targeting, or energy, or looking at attentional disorders, or what have you. Just cultivating that allyship with an adolescent who is initiating their struggles with a substance use is incredibly important. So I guess the message there would just be to go for it. And there certainly are not enough adolescent addiction specialists out there to meet the need. So it's a requirement that generalists enter into that space as best they can, and recruit resources to do the best job they can when they're doing it. But we can't be on the sidelines, that's for sure, because no one's there. We have to.
Thank you.
I was muted. One comment about the naltrexone injections, that some people have had a little bit of difficulty getting it in the first place with insurance since it's off label. So I don't know how you guys are handling that when you're using it in the setting of amphetamines as opposed to alcohol.
Right.
And yeah.
Yeah, one of the most common settings that we use it is actually post-overdose.
Mm.
So someone comes in, they're using stimulants, they overdose, and there's the whole thing of the naloxone drips, right? So you put them there, depending on whatever the dose of street fentanyl they got. Sometimes they can be knocked out for a long time, and have recrudescent, narcotization, so to speak. So their respiratory rate goes down. You got to put them on a drip. You can go to the ICU, this kind of thing. And what you can do is just sequentially test them with doses of naloxone to confirm there is no opioid dependence. And when you've satisfied yourself clinically that this is clearly not someone who has opioid dependence, give them a dose of oral naltrexone, and then actually administer the Vivitrol. So that's sort of the setting that we've been using it, where someone who's opioid overdose will pass muster for the insurance companies. So that's been the most common scenario.
If I may, in my case here in clinic, the way I get it, and I do the same at HQHC in downtown LA, most of us, we have had any alcohol at some point in our life.
Yeah, right.
The ICD-10 code for alcohol use uncomplicated is F10.9, and they always cover it. That's it.
That's great. Yeah, that's great. Yeah.
Little question, Dr. Herring. On some patients in which you have comorbid usage of stimulants plus alcohol as well, right? Let's say they've been drinking alcohol 1 liter. I bet you see more intake than that per day, right? And also usage of methamphetamines. How do you gauge the usage of bupropion in that setting when the potential withdrawal from alcohol can lead to these potential decrease on seizure threshold that the bupropion conveys? Do you still start it like waking off? Do you start at a lower dose usually? Do you prefer to delay starting bupropion at that point?
That's a great question. Maybe just stepping back, bupropion. There's many emergency physicians who will never touch that drug with a 10-foot pole, because they've seen an overdose that they cannot fix, which is just, it's a quote pill that can kill for infants. The overdose is quite extreme, where you just have these intractable seizures, kind of like a TCA. So it is real. It can be dangerous in higher doses. So in the person who is at risk for alcohol seizures, if they have a alcohol use disorder that is severe enough that they're routinely or having seizures, yeah, I probably want to get that under control first. Um, the Our treatment of alcohol use disorder is always at this point really involves utilization of a gabapentinoid, um, and or valproate, and or baclofen. So we're usually involving anti-epileptics as part of our long-term treatment. Um, and um, if you have depression in the setting of alcohol use disorder, bupropion is quite a good option for that. So I would say it's a tailored approach where if you have very disordered complex use with frequent hospitalizations for severe withdrawal that are complicated by seizure, that person needs to get just basically controlled, before I would start bupropion. But for the larger group of people who have a little more stability there, then I would include bupropion. And I see Steve's hand is up.
Works. Okay, I can still talk. Good. So great presentation, Andrew, and you're listening. Great questions. One of the questions I have is how do you sort of leverage the overamped experience in the emergency room to facilitate a life shift in terms of people's relationships to methamphetamine?
Yeah, I mean like just yesterday, I was working with a guy and I'm talking to him and he's like, and tech walks by and he says, "Oh, that guy just left a recording equipment in front of the door, you know." And so that would be and this was we hadn't actually been talking about we've been talking about opioids, and yet we hadn't even gotten to the point of revealing that he also uses methamphetamine, which became readily apparent when he started worrying about the ER tech taping him with the secret recording device. Um, I know it seems a little simple, but in that patient and in so many, food and rest are just such a big part of engagement. I know it seems silly, but it's just, you know, he ate 3 sandwiches. And along the way, we kind of started having this conversation about, you know, there's this, it's such a stereotypical and common progression where you start sort of seeing shadows become a little intrusive, right? You start worrying about people creeping up on you, and then it descends. And I found you can really engage people on not saying like, okay, you have this fulminant, schizophrenia, but God, it's kind of bothersome to have to worry about shadows. It's kind of bothersome to be kind of to be hyper vigilant about people creeping up on you. And here's a tool that I can give you right now that helps chill that out. So we in a clinic space, an ER space, just being really ready to utilize a little olanzapine, a little lorazepam, and that can kind of build that trust of like, hey, I've got a tool that was helpful for you in this moment. If you want to keep going with it, then I can prescribe it, and you can meet my colleague in the clinic tomorrow, and then we can and you can keep this train going. Um, so that engagement, again, can be long. So that's where that partnership with the navigator, who can be working with someone over an 8-hour stay or 6-hour stay or whatever, to find that moment to get in there with the hook of maybe I have something that you in your moment can see as being of self-interest to you. Like I'm not fighting the frame you're in. I'm not fighting your use. I'm just saying I might have a tool that you could fit into this sort of cosmology of wherever you're at, that could attract you to come back one more day.
Thanks.
I did want to go back. There was one person did make a comment early on that I skipped over, that they mentioned that sometimes it may not be, and perhaps this probably differs depending on the emergency department, but maybe at their site they felt that 8 hours is an unreasonable, like it just like wasn't feasible with bed availability in the emergency department, that these kind of lengths of stay have, and that perhaps considering like sending them to a detox, or are there other places that you've had success letting people kind of sleep it off? Like we have in LA, we have a sobering center that sometimes if they're awake enough that they can get up and walk around, that's somewhere they can go and sleep and have food. But
Yeah, I mean, I agree that it's not feasible, but
yeah,
it happens anyways.
yeah.
Right? Is there like so many things about the ER are unplanned, and just sort of the, what happens. Like, I love the idea of intentional spaces that create this place for recovery after methamphetamine binge. I am disappointed that they often leave the medical system and enter into the behavioral system in a way that is disintegrated. So, ideal state, um, there be a way that the medical integration could follow along with them. So that is the only risk with some of these alternate settings is, I do find that many folks using methamphetamine really do have a lot of medical needs, whether it is these sort of associated toxicities or it's other things that are not necessarily available in the behavioral health context. So providing both would really be ideal.
And then
But
I know we're getting close to ending time. We had one other Q&A. Someone was asking, what do you think we can do to change the culture in the ER around the care of patients with severe stimulant intoxication in order to avoid restraints and traumatizing patients more?
yeah, obviously an enormously hot button issue. This framework of a natural history of presentations in the ER that's moving from undisclosed, subtle subclinical use, then escalating, and then becoming, and then this fulminant or agitated, and then a crash. Just that in itself is intended to be an intervention specifically for that, so that people recognize that they're just seeing this one highly disordered moment in a more complicated life history. So that is the intent of this framework. And then, um, we do really need to look at how the architecture and the structure and design of these settings. I just can't emphasize enough how the way a high quality modernized um, psychiatric medical emergency department is physically designed and laid out has such an enormous influence on what can and can't happen there. If you have a typical crowded medical ER where the risk of someone harming themselves or harming other, unfortunately, is incredibly high. And in those settings, chemical and physical restraint is often, at great moral injury required. So currently there's something called Prop 1, which is part of the Prop 1 funds that hopefully a lot of people voted for. They're rolling down $4.4 billion in funding to create high quality brick and mortar structures for managing this mix of psychiatric and substance use related emergencies. And that's really what we need to do, to be able to get to this place where we can provide more humanistic, less traumatic continuum of care throughout these acute phases. And unless we build, there's really, not to be a little cynical, but no amount of interpersonal training is going to work. Like it's a bigger job. So thank you for bringing that up. It's hard to see. Yeah.
Yeah, we've had there's an interesting conversation going in the chat about like the use of topiramate and when people have decided to start that. Looks like perhaps some people are using it when there's a contraindication to using bupropion. some people have found people don't tolerate it well because it kind of dulls their sensorium a little bit too much. But
Right.
that also I would expect with the withdrawal period of use of amphetamines at the same time. So I know we only have 2 more minutes. So unless anyone has any like burning last minute questions and you want to raise your hand, I know I speak for everyone in saying thank you so much, Dr. Herring, for your wonderful presentation and all the work that you do for people with substance use.
Well, it's a great pleasure to be here, and thank you so much for the both the insights that were offered and the question. I learned a lot, and really appreciated the opportunity to be here.
All right, thank you, Dr. Harry. Thank you, Dr. Taylor, as well for moderating this session. Thank you so much to everyone who has attended. We will obviously be sharing the recording for this presentation and the slides as well. Please look out for an email from Tiffany, who is the coordinator for this session. And also there will be an evaluation that will pop up after you exit this actual session. So please feel free to fill out the evaluation if you're looking for CME credits or trying to gain CME credits for this session. Again, complete the evaluation and feel free to reach out with any questions. I think that's it. We're at the top of the hour. Thank you again for taking the time to present, Dr. Harry, and thank you all for being a part of this session today. The next one will be on Friday, November 15th. Look out for that email in your inboxes. Have a great weekend.
Bye-bye.
Bye.